All right, welcome back, and we've been submitted a case from a recent attendee of our 3D All-on-4 class, and we want to evaluate a plan for a potential excuse me, I have the hiccups this morning, fixed hybrid restoration. So let's take a closer look at our plan, and the good news is obviously this person learned quite a few things at our program. One was how to put the implants in, how to do a rough planning, how to simulate multi-unit abutments, angulation of abutments, and they just have some questions in regards to depth positioning, determining the space required, and then determining implant spacing and positioning just to fine-tune the plan. Now, one thing I do want to make sure that, as those of you that are watching this video that may not be familiar with our course, is that we don't believe in doing the final planning on these kind of cases, because typically these are going to require a bone foundation guide or a bone reduction guide. And so what we believe in doing is doing a pre-planning, which is determining can the case be done, showing the patient what the possibilities are, and then utilizing the services of a third-party laboratory to do the final planning under your direction. But you have to give them some direction to begin with, and this is a good exercise, in being able to determine what is possible. So please do keep that in mind. This is not a final planning, but more about a determination, can the case be done? So the first thing I want to take a look at is, as we go back, I generally will start just from a determination perspective at one of the anterior teeth. Now, one of the things that we always must have before we can determine what's possible is we need to have a picture of where the incisal edge is going to be. And in this particular case, the doctor has let me know that the incisal edge is going to stay in the same position, because we're going to assume that the patient is in a good bite, good vertical, no alterations are required there. So from my perspective, that's one thing. Now, one thing I do like to do to be able to make my planning a little bit easier is there are times where I would like to bring the CEREC data in here. Maybe I would add some teeth back here. Maybe I would make some minor changes to the overall look, just to give you an idea. But again, from a rough planning perspective, not necessary. But let's go ahead and take a look. And the reason I start in the anterior is just to get an idea of how much bone reduction I'm going to need to do and what my level of bone is going to be moving backwards. One of the things that we're big proponents of is making sure that we have level bone all the way across. So if we have, for example, X amount of bone reduction in the anterior, we don't want our implants to have this wavy look. So, for example, I'm not saying that we would reduce it in this particular case all the way across like that, because certainly in the sinus area that becomes a challenge. But what I don't want to do is have implants here, and then here, and create this wavy look where we have uneven bone positions and then we have unhygienic restorations. So from a general perspective, what I like to be able to do is find out where I need my implants to be, and then even if it's at an angulation like so, for example, I just like to know that we have a flat contour of the bone, so that way we can place our implants. And sometimes we'll place our implants deeper than they may need to be restoratively to allow us to have a hygienic overall restoration on these fixed hybrid cases. So to do that, I'm going to start here in the anterior. We know that by default, this yellow pilot drill path on the software, on the Galileo software, is set at 15 millimeters in length. So I can rough use that, and I can say that, hey, this is my incisal edge. Okay, and since this doctor is telling me that our incisal edge is going to stay the same, I can then use that and measure 15 millimeters up and have the placement of my implant. So in this case, I would probably, for example, drop my implant to be about right there, and that's going to give me my 15 millimeters of space. Now from this position, I can now work backwards in terms of determining my overall bone height in the posterior as well. So one of the things that I believe when I look at this posterior implant is that that level of bone reduction right here, getting that level of bone reduction may present a little bit of a challenge right there. So surgically, so what I would probably, my experience has led me to believe that usually we probably won't need much more than something along this line right here. And I think 30 degrees is probably going to look more a little bit like that. And I would say that that is probably more along our lines there. Okay, then I'll go ahead and do the other side as well, and same thing. Go ahead and drop this down here. Now I do like to get 4.3 millimeter implants in. It's just my personal preference, and I believe through bone expansion techniques, maybe idealizing the placement a little bit better, maybe even in some cases slightly more subcrustal placement, and even a little bit of bone grafting here, for example, or use an osteodensification or expansion can help us achieve that. So I like to achieve at least a 4.3 millimeter implant. Have we done cases with less? Of course, but generally speaking, my preference is going to be that. Okay, so maybe something along this line. Now, very rarely do I say that we should put the implant where the bone is maximized, but on these fixed hybrid cases, that is the situation because we're going to use multi-unit abutments to correct the angulation. So we have a little bit more room for restorative compensation there. Okay, then we'll start moving forward, and for the time being, I'm going to leave this implant alone. It's not actually necessary there, but this may be a situation where I don't want to put my implant in between teeth. I would prefer to actually put it in a socket, and the reason is I will probably have more bone width here due to the root, and I might be able to get my 4.3 millimeter implant in, and I would just finesse this a little bit here. And here you can see we probably look like we're using a 17-degree abutment there. That's correct. So with the 17-degree abutment, we can see that our placement is going to be a little bit lingual, the screw access at least, and that's good there. The other thing I also like to take a look at is this implant, if you take a look at it right through here, is off the long axis of that tooth. So this may be a situation where I'd like to go a little bit more like so, and just kind of get the implant more in the correct upright position here. And then what we may find, I'm going to actually go ahead and delete this implant. What we may find is instead of putting this implant at the lateral position, we may want to move this just like so. And now suddenly we start looking like, hey, we might be able to get there's our 15 millimeters of space based on that incisal edge position right there. Okay, and then we might be able to start getting the 4.3 millimeter implant in. So, and I'll slowly, once I get the angulation correct here, and I'll slowly just start moving this implant a little bit more mesially along the way here. And here I'm finding this is where I'm going to have volumetrically my most bone. So more than likely this is what I would do on the patient's right hand side. And then same thing here. Again, if we take a look, we can see our teeth are going this way, but our implant is going that way. So again, not that again, you can get away with many things, but here this is going to help us avoid that sinus area, the nasal sinus, and get our implant in a more ideal position here. And one of the things I'm looking at here is the incisal edge being level, my occlusal plane, coming back from some of our other teachings. And then again, start with the 4.3 and then see what does it take to get a 4.3 millimeter implant in. And as you can see, the farther back we go, the less bone we have. So maybe this is going to require going a little bit more anterior, and it looks like we start getting the amount of bone space we need. And then we start looking at maybe tip and tilting our implant. And now this is where surgical skill comes into play, and being able to consider the use of osteodensification and different things along those lines as a possibility of achieving our torque and implant width. And so ultimately this would probably be my estimated plan of being able to say, hey, yes, I can do it. Now, what I would do then here is go ahead and duplicate this, and then now I have a plan that I know I can get away with, and then now I may consider adding in another implant from a over-engineering perspective. And then I said, listen, if I had to place another implant, what would that look like, and where would I put that if that were a requirement? And everybody's going to be a little bit different. Some people are not big believers in the all-on-4 concept. They just don't believe in it for whatever reason. So I may say, you know what, I could possibly squeeze an implant in here, do some simultaneous grafting, go ahead and use the other 4 implants for immediate load or support. Again, I would look at my bone level positioning overall to make sure that I don't have big dips and waves, and then maybe I would plan an implant on this side as well, just like so, to see would I be able to get away with a 5th implant or a 6th implant, and which side could I do it on, and all of those things. Because to me, one of the negatives with all-on-4 is that you really depend on all 4 of those implants integrating and working out, and for immediate load, we're really dependent on all 4 of those implants gaining the stability that we need. So I always look at what are my alternative plans. So one, for example, situation here might be that we could consider something along this line, surgically a little bit more complicated, but we could consider putting an implant right in the center. Okay, maybe we'll go to a 3.5 on this. Just like so. And then we can consider having 1, 2, 3, 4 alternative implants. And I'm not going to go through and put these in the exact spot, but just giving you some ideas of more of like an all-on-5 concept, where if this implant didn't work because of lack of bone here, or avoiding the foramen here, the options exist. So hopefully this makes sense. These are some of the things that we do cover in our all-on-4 program. Again, we're not working on making the final plan. We're working on making a determination, can this case be done, how complicated is it, and go from there. The one other thing I would like to point out, actually, as I think about this, is the consideration for maybe doing a lift. Okay, so if for example, we didn't need to reduce significant amount of bone back here, okay, we could actually consider doing there's a possibility of consider doing a internal sinus lift here and putting one implant right here. Again, assuming that we're not going to do significant bone reduction all the way this far back, and this is where having these teeth back here would be, ultimately helpful to know how much reduction and how much restorative space that you do have. So that would be very nice to know. So that would be very nice to know there, because I think this can be done as an internal lift, and now suddenly we have some alternatives here, and we can avoid using a tilted implant, say, for example. Let's take a look at the other side as well, and the other side would prove to be a little bit more difficult. Okay, so maybe what we could consider doing is an internal sinus lift on this side. Traditional, we can do 3 implants on this side and then 2 implants on this side, and have some options there as well. So that's the point of the 3D technology, the final planning. The good news is we know that without question this case can be done. Based on the information provided, based on the bone that we have, and then it's a matter of going through, once a patient has accepted treatment, and deciding which exact plan we want to go with, and then working with your third-party laboratory to fine-tune your plan based on your final restorative positioning. So hopefully you found this very helpful, and congratulations on coming to the class, learning many of these things, and then getting your first case acceptance. So thank you very much.